let's talk a little bit about who the functional vision head impulse test is really appropriate for. So, before we talk about who this test is appropriate for, let's just review a couple things. One, we know that this all-star reflex that's called the vestibulo-ocular reflex is one that we look at very often in the vestibular clinic. This is because the VOR is so important for everyday head movement. We know that it provides compensatory eye movements in response to head movement, and it's very measurable. The eye movements are equal in amplitude and speed to the head direction, but opposite, right? So it's very easy to measure. And really, the VOR, it helps us maintain stable gaze while our head is in motion. So critical for walking, driving, and all the activities we perform on a daily basis. Now, in the clinic, we already have a ton of VOR tests that we utilize on a daily basis. And really, they're focused on low speed of head movement versus faster speed. So we know that daily head movements sit in about this mid-frequency range, and we like to test below, throughout that head range, and even above it. So the caloric test many of us use is the lowest frequency evaluation. We've got that rotational chair assessment, which really looks at a wide spectrum of those mid-frequencies. We have dynamic visual acuity and gaze stabilization tests. Those are a little bit higher, maybe typical daily head movements for most individuals. We've got the vHIT test, a wonderful test that, again, helps us look at those high-frequency head movements. And then this new test, the functional vision head impulse test. Now, you'll notice we have a ton of tests that are all overlapping in frequencies. Why do we have so many? And really, what's the difference? So before we talk about who the fvHIT is appropriate for, we need to just kind of spell out the differences between these tests. So let's take it back. First, we're going to talk about dynamic visual acuity. This dynamic visual acuity is a test that looks at what we call the functional assessment of the VOR. And really, the question we're trying to answer is, what is the smallest text size that you can read? Ultimately, when performing this test, the patient is moving their head at the exact same head speed, and the optotype is flashing on the screen, and it is changing in size. So as they get the answer right, the size gets smaller, so it gets a little bit harder. And as they get the optotype direction wrong, that optotype gets larger. So that's the purpose of the test. We're just trying to figure out what their dynamic visual acuity is, that smallest size that they can see clearly. Now, the gaze stabilization test, kind of similar, but some things that are different. Really, we are trying to answer the question, at what head speed do words become blurry? And so the thing that is changing here is the head speed. The head speed changes. It starts to get faster and faster as the patient gets the answers right. If they get the answer wrong, then the head speed slows down. So for this assessment, that optotype size stays exactly the same, and the changing element is how fast the patient is moving their head. Then we have two more tests that we've mentioned, this video head impulse test and the functional vision head impulse test. So the video head impulse test you may be familiar with. This is a diagnostic assessment of the VOR. And ultimately, we are trying to quantify the VOR gain, or the amount of eye movement in response to head movement. So we move the head, usually at about the same speed. It's 100 and 150 degrees per second. And the patient is looking at a stimuli dot that is stationary, usually on the wall or on a screen. And the patient just has to keep their eyes fixated on that dot. The clinician moves the patient's head, and we are measuring to see that gain of eye movement. And really, from a diagnostic standpoint, it becomes most important when there is reduced gain, so the eyes don't move as expected, or there's catch-up saccades. So the eyes have to do these corrective eye movements in order to keep stable vision on that dot. So this is very helpful because we can perform it in the 3 semicircular canal planes, lateral, RALP, and LARP, and we are able to identify dysfunction in those canals or with a certain part of that canal. The functional vision head impulse test, it is a functional assessment of the VOR, so similar to DVA and GST. But really, the question we're trying to answer is, at what speed and in what canal does the optotype begin to become blurry? And so we've got the changing element is head speed. So we're looking at different head speeds, and we measure this in acceleration at 1,000 to 7,000 degrees per second squared. The optotype size stays the same, And the head speed is what's changing, and also the head direction because we're doing lateral, RALP, and LARP canals. So this functional vision head impulse test, as we've learned, is that functional VOR evaluation. It's the exact same technique as our vHIT, but we're looking at a range of head accelerations. The patient is supposed to say which direction the optotype is facing on the screen, and the outcome measure is that percentage correct in each acceleration then. So it really combines those fast random head impulses that we're used to doing in the vHIT for the 3 canal planes, and it also combines the optotype being displayed on the screen and that outcome measure. So very, very helpful piece of information here. And we've looked a little bit and we'll continue to look at how to perform this test. But let's talk a little bit more about these high frequency VOR tests. We've talked about 4 of them: DVA, GST, vHIT, and the functional vHIT. And one way to look at these, the difficulty of these tests, is how fast they are. So if I were to organize these tests from slow to fast, I would say DVA is my slowest test. So this may be my easier test for some of my patients. And the vHIT and the fvHIT are my more difficult tests because they're faster. And so when I have a patient coming into the clinic and I'm trying to figure out what tests I'm doing, I may start with a slower assessment to see if the patient can perform that. And if they do it well, then I may move on to a more difficult test. This is not unusual to what we do in the vestibular clinic all the time. Think about balance assessments. When we do a balance assessment, we usually start with an easy condition. The patient is standing on a flat, firm surface with their eyes open. Did the patient do well? Let's make it more difficult. Have them close their eyes, have them on a dynamic surface, have them with, the visual field changing. So we make it more difficult for that patient and we continue to test the point at which their system breaks down. It's similar when we're looking at these high frequency VOR tests. And we know that the things that these high frequency VOR tests evaluate are a little bit different because they're different speeds, they're different canals. Our DVA and GST are up and down and left and right movements, whereas our vHIT and fvHIT look at those canal planes. So we have to start looking at these tests in a few different manners to decide what questions are we trying to answer about that patient. So we know that head speed is one thing to consider when you're trying to choose a VOR task. Because for your patient, you may want to start with something slower and make sure that they can achieve that and then make it more difficult if they do well. But another thing that you may want to think about as you're performing these tasks on your patient is really the cognitive load of these tasks. So if I were to rearrange for the lowest cognitive load, how much their brain has to work at the test, to the most cognitively demanding task, I'd probably rearrange them in a slightly different way. The vHIT is a very automatic response. We are measuring the VOR gain. Generally, as long as the patient is awake, their eyes are open, and they're looking at the stimuli dot, they can do this test. So it's really not a high load for what the patient has to do. And we're very used to seeing what this vHIT looks like. Maybe a little bit more difficult for the patient is that DVA or GST test because they are given a task. We want them to identify the direction of the optotype. So they're seeing this optotype move and they have to tell us which way the open part is facing. So the brain actually has to do something. The patient actually has to respond. The good thing about the DVA and GST for the patient is that it's a very predictable movement. They can move their head. A lot of times a clinician moves the patient's head for them. So it's a very predictable motion. And the patient just has to answer left, up, down, right. So it's a little bit more challenging, but not the hardest. One of our hardest and highest cognitive load tasks in this high frequency VOR range is the fvHIT. Because one, we are doing this impulse head movement that the patient does not have much warning for. And two, they actually have to respond and answer a task similar to the DBA and GST. So not only do they have an unpredictable head movement, they don't know which way they're going or how fast they're going, but they also have to answer something. They have to do a task. So when we look at our high frequency VOR tasks, another way to think about this is how cognitively difficult is this for the patient? So speed is one consideration. So maybe I do start with a slower speed test and make sure the patient can do it. And then I turn up the the speed, I turn up the cognitive load, and I try to find the point at which my patient starts to struggle. Because our patients are coming to us with these symptoms, and we need to identify at what point they're breaking down so that we can prescribe the appropriate rehabilitation plan for them. In general, looking at these high frequency VOR tests, we know that when you've got more tests in your battery, that can really help simplify and personalize really the therapy recommendations for that patient. And the choice of which test to do, DVA, GST, vHIT, fvHIT, really depends on your clinical judgment and the patient that's sitting before you and their complaints. Because depending on what they're complaining about, you may choose a different test sequence to identify where that patient is breaking down.